much. So thank you everybody for joining us. I'm Brian Persing, one of the medical oncologists over here at Mitchell Cancer Institute. And they asked me if I would be willing to give some updates on advances in lung cancer. And I think there's probably really so many updates that kind of narrowing that down was a little bit difficult, but we got it into, I think, a manageable amount of time and slides. And I was going to go ahead and if there are questions as we're going, I want to try to make sure that we can stop and answer those questions real time. So if you're comfortable unmuting yourself and asking a question, that's great. If you'd rather type it into the little chat box at the bottom on that little bar that you have, they'll make sure that I know about those, and we'll try to answer those as we're going, because you know, as we're learning about this, there are going to be questions that pop up, and sometimes if we don't ask them and get them answered while we're going through it, we end up getting to the end and don't remember what the question was. So we'll try to do those real time as long as technology cooperates with us. So this isn't going to be a CME talk, but I did throw my conflicts of interest in there just in case anybody had questions about what I do outside of the office here. So when I started looking at what we were thinking about as far as advances in lung cancer, there's a couple things that I think are vitally important. The first thing is it's really important to know where we came from. And so when we're talking about the advances, we want to know where we sat and currently where we sit. And so that background is going to include some frequency, how often this happens, survival, and then talk a little bit about prevention, because that's really one of our greatest advances, and that's really been happening over 30 years, right? We talk a little bit about screening, and there's some new screening guidelines that have come out in the past few years, and kind of how we select those patients. We'll talk a little bit about diagnosis, and that'll include biopsy techniques, pathology. We'll dive a little bit into molecular treatments and therapies based on those. And then last but not least, we'll really talk about kind of some of the treatment, which is to me, because that's what I do, is really most exciting, and seeing the benefits that patients are deriving from the clinical trials that have happened and all of technology that we're seeing today. So I put on here November, and I think there's a few things. The first thing, people that know me know that I typically don't have a beard. And so No Shave November is taking place. And so No Shave November, there are two things, Movember and No Shave November. Movember was a group of folks from Australia, 12 guys that decided they weren't going to shave, promoting men's health awareness, not just cancer awareness, but men's health awareness. And then No Shave November started in the United States. They've raised millions of dollars. And the idea is you don't shave, and everything you spend on shaving cream and razors for that month, you donate. That was based off of a gentleman that had colon cancer, and his family started that. So it's No Shave November. But the other thing that we know, and obviously we're doing a talk on lung cancer this month, is it's Lung Cancer Awareness Month as well, okay? And I know a lot of people know what the ribbon is for breast cancer, but who knows what the color of ribbon is for lung cancer awareness? You can unmute yourself and yell it out or type it in.
Pearl.
Blue.
Blue. A pearl and blue. What color? So it's pearl or white, right? And you know, the universal color for cancers is purple, but it's actually white or pearl. And so there are, like, if you look, like mesothelioma has a color as well. So when we talk about just general thoracic cancers, it's a pearl ribbon, so white or pearl. So when we think about lung cancer, and this kind of starts into the background, we think about lung cancer, and it's divided into kind of two major categories: non-small cell lung cancer and small cell lung cancer. Obviously, not a very creative group that put this together. When we break that non-small cell lung cancer group up, we find that adenocarcinomas, squamous cell carcinomas, and large cell carcinomas comprise that non-small cell lung cancer group. Small cell lung cancer comprises about 13 to 15% of lung cancers, while non-small cells the other 85%. About 70% of those patients are adenocarcinoma, about another 25 to 30% are squamous cell, and that last little bit fits into the large cell carcinoma group. So here's always the statistics that I think are most kind of staggering when we think about lung cancer and other cancers in the United States. You can see that on the left side of that slide, we have breast cancer comprising about 280,000 cases, new cases per year of breast cancer. But you'll notice breast cancer, when it comes to estimated deaths in 2020, represents about 42,000 deaths. And so there's a discrepancy between the number of diagnoses and the number of deaths, where lung cancer is 228,000. So it falls short of breast cancer as far as frequency. And if you think of breast cancer only happening in women and lung cancer happening in men and women, if you thought about that being as really a less, 1% or less of breast cancer happens in men, it's a large number of patients that have lung cancer because it's across both genders, right? But when we look at the deaths associated with lung cancer, it's 135,000. And one of the major sources, and this is the American Cancer Society, and this is predicted this year, because one of the issues that we run into when we're talking about deaths from cancer is we're really somewhere between 3 to 5 years behind, because it takes a while for the SEER data, SEER, that's an epidemiologic kind of evaluation of causes of death. It's a couple years behind. And so I have on the slide here, and I'm not so worried about you seeing all the writing, but it's females on the left side and males on the right side. And this is trends in death cancer rates between 1930 and 2017, okay? Well, some of it is, and until we hit the 50s, we weren't very good at figuring some of that out anyway. So the question is the data prior to 1950. But if you look at lung cancer, which is that red that pops up and has a pretty high peak, you're going to notice in women, that peak is around 2000, where men, that peak is around 1988, 1989. And this has to do with women entering the workforce and picking up bad habits of their male counterparts. But the fascinating thing is, why does anybody know why in 1990 to 2000 we're seeing this large drop off in the number of lung cancer cases? Any theories? I'm gonna start picking people out.
I think you would have to unmute them with the way it's set up.
Oh,
I'm not sure they can
them?
unmute themselves.
Oh, they can't unmute themselves?
But Carol says regulations against smoking in the chat, and not smoking as much as the consensus.
So remember 1980, 1982 was when Surgeon General Koop came out and forced tobacco companies to put warning labels saying these are going to kill you on the side. And there was a concerted effort to stop smoking. And men did that before women, believe it or not. Okay. And that's why this curve, the second curve, kind of shows those peaks at separate times where men stop smoking earlier. It takes about 10 to 12 years to start to see a reduction in lung cancer rates when you stop smoking. And so, and we'll talk about that's one of the screening guidelines as well, but you can kind of see if we did that in 1980 and the peak was in 1990 to 1992, that's that 10-year gap between stopping smoking and the reduction in lung cancer that we see. And that has to do with DNA damage and other things that happen in the lung, all right? So this is looking at just men and women in 2020, new cases and deaths. And you'll notice the new cases in men and women are almost identical. But here's the interesting thing. Women do a little bit better than men. And there's some thoughts behind that. And some of that may be based off of some molecular testing on the lung cancers we'll talk about toward the end of the discussion today, okay? So the other thing that we understand is the more advanced the lung cancer is, so the higher the stage, the less likely somebody is to survive that, okay? I want you to understand this is 2009 through 2015 data. This is old, and we're going to see improvements in what we see today, even based off of trials from 2 to 3 years ago now, okay? All stages combined, 20% of people are alive at 5 years. That's not great. But for localized disease, we can see 57% of people alive. That was 60% on some data from 2017. So like I said, we're 3 to 5 years behind with the information we have. But you can see in people that have distant disease, that typically means it's spread outside the lung. So it's in the liver, or it's in the brain, or the adrenal gland, or the bone. 5-year survival is 5% or less, okay? And that's probably changing too, but we don't have the data out 5 years to prove it yet, okay? Why is lung cancer so much worse than breast cancer? Why is the mortality rate higher? Okay, it has a little bit to do with the aggressiveness of the disease, but it also is really, really important to understand that we're diagnosing these people at later stages. So if we had 40% of women with breast cancer present with stage 4 disease, these numbers wouldn't look that different then. And so one of the important things that we understand is screening and prevention are playing a greater role. So if you look at 40% of patients, not quite half, with a survival of 0 to 10% at 5 years, that's where the numbers and where that heavy number of deaths over the time frame tend to happen, okay? So if we say an earlier stage is better, what's even better than an earlier stage? Prevention, we know this. And so we understand that smoking cessation has played a vital role in improving that. We know that workplace regulations limiting cigarettes, we know that even restaurants and preventing smoking in public areas has prevented this. And so we know, and there's a percentage here that people will look at and kind of scratch their head. We know that there are percentage risks associated with these. What these percentages are is not the percent of people exposed that get it, but this is the number of people that had lung cancer and they went back retrospectively and said, what have you been exposed to? A lot of folks that work in the shipyard that may be exposed to asbestos, which is under that work environment, may also smoke, meaning you can get more than 100% on this because it's not pooling the cause, it's pooling what they've been exposed to. And we understand tobacco is the highest, but the most important thing, and I want to point that out at the bottom, is secondhand smoke now has been attributed to about 7 to 8% of lung cancer diagnoses and about 5% of lung cancer deaths. And so when we look at that 60,000 women and when we look at that 73,000 men, we have 7,000 cases of secondhand smoke causing a lung cancer death in the United States, meaning we still have a long ways to go to try to make this better. So prevention is key. How do we prevent it? We stop smoking. So May 31st is national or international Stop Smoking Day. You set your date. You do your inhaler soft tip nicotine-free inhalers. You do Chantix. You can do Nicorette. There's this cool thing called Lifebox. It's an app that you have on your phone, and what it does is it weans you off of the cigarettes by opening the box at the appropriate time. I mean, fascinating ways to do this. And what's the most important thing in getting somebody to stop smoking? The single most important criteria. You can type it in, they can yell it out.
Weight gain?
Well, weight gain is a risk factor for stopping, right? So now you have to gain 70 pounds to have the same cardiovascular risk as cancer. But weight gain is a side effect of stopping, absolutely. We know that that's a problem. The single most important thing in somebody somebody able to stop smoking is being motivated to stop smoking. I always say your family member can't stop for you. So the patient has to be motivated. An unmotivated patient, 5%, 7%, you talk about more than that. Oh, I can kind of pull the chat. Yeah, willingness, exactly. Yeah, willingness, not, those kinds of things. Oh, I can pull the chat. It gives me a little orange sign. Awesome. So I can see the chat too. Okay, perfect. So if we aren't preventing it, how are we finding it earlier? Okay, so when we talk about screening, there's a couple important things about screening. The first thing is it really has to be there and be able to be identified early. And in addition to identifying it early, we have to be able, with intervention, to prove it actually impacts survival or outcomes on the tail end. Meaning, finding something early that's never going to kill somebody doesn't help. And this is the questions about prostate cancer, which would be a whole nother screening talk in and of itself, okay? When we look at lung cancer, we've tried chest x-rays. Those didn't work. We tried patient questionnaires. Those didn't work. We tried pulmonary function tests. Those didn't work. We tried exhalation breathing tests. Those didn't work. We tried looking for cells in stuff people coughed up. That really didn't work. What's worked? Well, the thing we've proven so far is a low-dose CT scan, or a LDCT, has shown benefit. We're also looking at, and I didn't put slides in on this because we don't have the data yet, but there's a breathalyzer that looks for volatile organic compounds, and I did put a little piece in on that. But we're also looking at cell-free tumor DNA, looking for mutations associated with cancer, okay? And so this is on the left. Here's a chest X-ray. I almost pulled a radiology trick. On the right, well, that's the patient's right, but it's on the screen left, right, is a chest X-ray, and then on the right is a CAT scan, okay? And on the right, you know, I almost don't have to point it out. There's a white spot in the middle of the lung right here, okay? And on the left, they put a little arrow to show you where it was. We can see why chest X-rays aren't adequate. You just can't, you don't have the detail, okay? So the trial that publishes showed that, you know, if we screen about, 300 to a little more patients, we'll find a lung cancer, and it's somewhere around 600 to 1,000 CT scans to save a life, which sounds like a lot, okay? But we're moving those patients earlier and doing surgeries. And so the current guidelines right now for patients and determination on whether or not we should do these is an age 55 to 80. There's some argument maybe 75, but I know plenty of healthy 80-year-olds. A 30-pack year history, which would be a pack per day for 30, 2 for 15, a half for 60, you know, just a number of packs per day multiplied by the number of years you smoked, okay? And if it's more than 30 pack years, we can do the screening. And if you smoked in the last 15 years, if you quit 20 years ago, you know, based on that data that we saw on that survival curve, when the stuff came out and people stopped smoking, that risk for death from lung cancer drops off significantly, okay? The other thing that I think is important when we're screening these patients, if I have somebody that comes in a wheelchair and can't breathe and I can't send them to the surgeon to do a surgery to take out a lung cancer, does screening help them? The answer is maybe not, because we find it and then we can't do anything about it. And so they're very cautious in most of the guidelines, trying to figure out if there are people that don't fit screening based on strength or performance status. That really hasn't been entered in, and most insurance companies at this point in time don't include that as part of their exclusion for coverage, okay? What are pitfalls of screening? Because every screening test has an issue. The first one is false positives. So we see something that's not cancer. What happens? Well, now we have prolonged follow-up, which I put at the bottom, which is where we follow you up with another CT to make sure it doesn't change, and then maybe another CT so it doesn't change. We know even with the low-dose CT, that's equivalent to somewhere between maybe 200 and 300 chest x-rays. That sounds like a lot. It's less than half of what we do with the standard CT, but oftentimes that's going to lead to additional radiation if we find something abnormal. Reimbursement. So we had reimbursement issues. When this first came out and the U.S. Preventative Task Force said, let's go for it, let's roll this out to patients, guess what happened? Insurers weren't ready and they were denying these reimbursements. So patients were having to pay out of pocket, okay? Obviously, anytime we do a screening test, there's always anxiety, especially if you find something. And last but not least, the concern of false negatives. There's something there, but we can't see it. And so CTs, yes, these aren't high-res CTs. We do miss some things, but relatively speaking, it's still a lot better than not doing anything at all, okay? So this is the kind of the cool thing, and this is moving into kind of, we won't call it Star Trek, but we're gonna call it really kind of the next generation of medicine, and that is the ability to identify small amounts of DNA or protein or RNA that allow us to say, hey, this is a cancer signature. We need to do something about this. And so there's a new thing out there, and there have been some. I've even seen one of the evening news, national evening news things published some data or showed some data on this, and that's some lung cancer breathalyzer where you breathe in for a certain period of time. They measure for volatile compounds, organic volatile compounds in the respiration in what you breathe out, and able to identify cancer there. And then I think circulating tumor DNA that I didn't put in here is going to be one of those things we're talking about using for screening too. So the screening is only going to get better from where we are now because of the technology that we have. So it's an exciting time. The next part that I think is absolutely vital, and I think we've recognized this now going on probably 3 to 4 years, everybody needs to be on the same page, okay? And we find that a lot of times, especially in smaller communities where we don't have a pulmonologist and we don't have a thoracic surgeon, we don't have a radiation oncologist, we may have a medical oncologist there 1 to 2 days a week, those patients need to be evaluated at a tumor board or by a group. And by that group, it's not that the patient even has to be there, but their scan can be there, their biopsy can be there, and that team can come up with an approach appropriate for that patient. I think that we oftentimes forget that primary care is a vital role, especially now that we understand the importance of screening, but also the importance of not smoking, right? And so that lands with primary care. Pulmonologists can help with the biopsy, the staging, but they also look at lung function so that then the surgeon can decide, hey, their lungs are strong enough to do the surgery. Obviously pathology, and then radiation oncology from a treatment standpoint, medical oncology, and supportive oncology is gaining momentum here as well, because we understand that patients with lung cancer oftentimes have shortness of breath and other symptoms that everybody's thinking about, but nobody's addressing as well as we could, or they're having pain, or they're having nausea, or they're having some other side effect of treatment. And that supportive oncology, and historically they've been called palliative care, but it's hard to call it palliative care because we associate that with hospice. So we make sure that we try to include as many specialists as we can, not necessarily creating appointments for the patients, but having those people engaged. All right, so I'm going to break for a quick second there. Are there any questions or anything that we've talked about so far that anybody wants me to go into deeper information on, or has a question at all?
Give it a second, see if anybody types anything
I
in.
know, yeah. I tend to move quickly, so I want to make sure that I don't leave anything in the dust. Because we had another weigh-in on the chat on commitment to stop smoking, which is absolutely right.
Yes.
Commitment's number one. All right. Well, good. So we'll kind of sneak into diagnosis then, because that's a natural break point, because that's everything up into when we get the answer, right? And so once we get the answer, we have to have tissue to be able to tell patients what they have, okay? And we're going to talk about how we get the tissue, how we look at the tissue, what we do with the tissue once we have it, and kind of the new and exciting things that tissue allows us to look at as well. The tissue itself, when we do the biopsy, is typically of the part that's abnormal. The part that's abnormal can exist in the lung, but it can exist in other areas as well. So when we think about the lung, there are two major ways we get there. That's called bronchoscopy and CT guided biopsy. And I'll show you pictures of these in a second. Sometimes the cancer gets leaky, so we end up with some fluid around the lung. So a procedure called thoracentesis is where we can go in and drain that fluid from around the lung and look for the cancer cells in that fluid, okay? The other thing that we understand is if cancer metastasizes somewhere, if we biopsy that site where it went, we can get tissue and we can stage somebody at the same time. So there's an advantage to biopsying the liver if we think it's lung cancer over biopsying the lung, because we may not still know what's in the liver if we biopsy the lung and it's lung cancer. And we'll talk about kind of primary versus secondary cancers, okay? And that'll happen closer to the end as well. So bronchoscopy is where we actually, we're typically the pulmonologist. Now there are some surgeons that do this as well, but the pulmonologist typically goes down in the lung and sees if they can see something abnormal. They see something abnormal, they can biopsy that, okay? And that will be what we call endobronchial lesions. So you can see the trachea and then the bronchus. Most cancers pop up in kind of the outer part of that, you know, the outer part of the lung. Sometimes they're visible from the inside, sometimes they're not. If cancers are large enough and they're out toward the edge, a CT guided biopsy can help with this, okay? And that's where you go from the outside. So those are ways we get tissue. A fancier way to get tissue is endobronchial ultrasound. And that allows us to identify lymph nodes that are enlarged or look abnormal, and to actually use the ultrasound probe, which is this little pink, semicircle piece here, to identify the lymph node. And then they're able to put a biopsy needle through and get tissue out of that lymph node to confirm whether or not there's cancer there, right? And so this is called endobronchial ultrasound, or EBUS for short. This is the really neat thing. So probably about 6 years ago, navigational bronchoscopy came out. And that is where you use either a wire guided by some magnets, or in this case, you use a robot to be able to go out to the area that's abnormal. And we're able to go after little nodules now that are maybe 8 millimeters, which is about 1/3 of an inch in size or smaller, and get biopsy samples from those, when we couldn't do that before because we couldn't get there and we couldn't guarantee we get the tissue. We had to wait for tumors to grow. This sounds crazy, right? We had to wait for tumors to grow big enough to be able to get the biopsy, okay? And I've been in practice 11 years now, and that was commonplace in the first 3 to 4 years that I was in practice, where we'd have to wait for some cancers to grow just to be able to get a diagnosis. And sometimes we would send people directly to the operating room just to take it out. 5% of people, it wasn't cancer, and we ended up taking out part of a lung for somebody that didn't need part of a lung taken out. So this specific, this is the Monarch, and that's what's available here at USA Health. And it's I will tell you, I've been in on one of these. It's truly a fascinating procedure. And the nice part about it is the patient's sedated during this. And this kind of goes into the benefits and risks of each of these ways to obtain tissue. CT guided biopsy depends on going through the skin and through the lining around the lung called the pleura. That increases the risk of deflating the lung. We call that a pneumothorax. It needs to be a little bit larger size tumor. It should be out toward the edge, and the patient's awake during the procedure because they actually have to hold breath, which reduces the risk of the pneumothorax. Obviously, this is painful, it's not comfortable, and most patients I've had that have had a CT guided biopsy don't want to have another one. The advantage to CT guided biopsy, though, is it's really available at more centers because this requires a radiologist and a CAT scanner, which is available at even small, even rural centers, okay? We are able to use a bigger gauge needle to get more tissue sometimes, which can be an issue in lung cancer. We don't always have enough tissue. And any practitioner can request that this be done, meaning you don't have to have all the specialists sitting there saying, let's get a biopsy. It's something that can be done even by primary care as far as ordering that test. Versus bronchoscopy. So the pitfalls of bronchoscopy, it does require sedation and intubation typically, okay, to do it appropriately. Now, it's normally not, full, it's usually a light kind of conscious sedation. It's usually not the heavy kind of sedation, but the nice thing is you're asleep during it, which is an advantage as well. We can biopsy smaller lymph nodes there, but we end up with smaller biopsy samples as well. And typically it's going to have to be performed in experienced centers. So the advantages, you're asleep. The pulmonologist who's doing this typically evaluates the patient prior to doing it, meaning it's somebody that has experience with lung cancer and it's already able to weigh in based on their experience, what they've seen. The risk for pneumothorax is low. And with EBUS, we can stage the patient and get a diagnosis all at one time, okay, which is exciting. The other thing that we're able to offer here, and Dr. Herrera is our pathologist that helps us with this, is rapid on-site evaluation, where a pathologist looks at the tissue real time. So the biopsy's taken, they put it through a couple quick stains, they dip it in these stains, they hand it to the pathologist. The pathologist looks at it and says, I see cancer, I don't see cancer. If we don't see cancer, it allows us to do another pass to get more tissue to try to make sure that by the time the patient wakes up from that procedure, we have at least, yes, it's cancer, or no, it isn't. Maybe it's sarcoidosis, maybe it's lymphoma, maybe it's infection. We don't really know sometimes when we go in, and we can give them a better idea what they may have. It also allows us to send off appropriate testing at that time, meaning instead of waiting a week or two to get a pathology report back, we can say, gosh, you know what, this was cancer. Let's go ahead and send off liquid-based molecular testing or liquid biopsy. It's not truly a biopsy, but send off that other information. Or if it's a lymphoma, send off flow cytometry. So this is an exciting way to do this. It's a little bit labor intensive. It depends on the cytotechnologist. It depends on the pathologist. But the nice thing is we get that immediate assessment to make sure that we have the answer, and we get real-time feedback. So when the pulmonologist is doing this, or the radiologist is doing this, they can say, hey, listen, guess what? I didn't get enough, but you're right at the edge. I think you're going to get it with the next pass, and they do another pass. All right, so that's diagnosis. Does anybody have questions about how we do biopsies or how we look at the samples or any of those kinds of things? Right. All right. If you do, pop it in the chat. We'll keep going, but always, and if you have a question while we're going, pop it in the chat too. That works great. So we make a diagnosis and that's all we need. No. We now have to know more about the patient and more about the cancer. So we want to know about the stage. And what I did is I included, this is the AJCC8 staging system. This is our most current staging now for lung cancer. And it kind of breaks it up into that pink and purple, which is our stage 4 disease, darker blue, which is our stage 3 and B and stage 3C. And if you look at it, it's set up with our T staging here. That's our tumor. So that's either how big it is or does it invade into something close by, okay? And then it has our N staging, which is our lymph nodes. No lymph nodes, that's N0 versus N1, N2, N3. And then metastatic disease, which is our M stage. And that means it's spread to another organ. That stage is important when we're coming up with treatment planning, but it's really only part of the picture. That used to be all the picture 11 years ago. But now, you know, what's important as well is lung function. When we're talking about immune therapies or surgery or radiation, we talk about molecular markers, which are kind of the Achilles heel of these cancers that allow us to treat the problem instead of treating global, trying to create global pandemonium with chemotherapy sometimes. And then immune markers. So is this sensitive to immune-based treatments, checkpoint inhibitors, as we call them? Okay. Last but not least is the patient's strength. We call that their performance status, right? If a patient's confined to a wheelchair and I'm getting ready to give them knock me down kind of chemotherapy, that may not be the best decision, right? We need to adapt our treatment plan based on how the patient looks. And that's something that's different from where we were 20 years ago, maybe even 15 years ago, where everybody got chemo and there was only bad chemo. There was no good chemo at the time. We have better chemo agents now, but it was still really, really tough, okay? And so we talk about staging, which was the first block on there. Staging, we typically will do a PET scan and an MRI. So we've looked at CTs. The advantage to a PET scan, this is in the right lower corner, is we have what we call our MIP image, which is just the black and white full body picture where we see the mass, and I don't know if you guys can see the pointer or not, but we see the mass, and then we see a lymph node here. And when we look on the CAT scan, you can see the mass at kind of the 2 o'clock position, okay? But the lymph node behind the blood vessel there, we don't see as well. Where when we pair those two together, we put the PET scan on top of the CT, you can see that there's a lymph node there, and we can see that the mass lights up as well. That lymph node we might have ignored in the past. So it allows us to better stage patients when we're doing our PET scans. Okay. We also do an MRI brain because there's a percentage of patients, depending on the tumor type, small cells much higher, but it can happen in any tumor type, for brain metastasis to develop. The earlier we find those, the better. And we'll talk about why, because our radiation techniques have improved as well. So we're going to look at this slide because I'm going to break it down based off of how we understand treatment. Like I said, for the purposes of this talk, this is primarily non-small cell discussion right here. And we can talk about the two benefits in small cell at the end here. But when we look at this graph, or we look at this table or chart, there are really two pathways on here, the surgery pathway, and I'm going to say radiation chemotherapy pathway, that demonstrate what we would describe as curative intent treatments. Treatments designed to make sure the cancer is gone and doesn't come back, okay? If you look at the systemic therapy that sits outside this red box right now, systemic therapy today is not curative, okay? There may be people cured, okay, but that's not our initial intention when we start the treatment, okay? And we'll talk about what our initial intent is as we get into that. So as I was doing this talk, I was trying to think back on what I knew when I started 11 years ago and the benefits we saw 5 years ago, okay? And there's been so much changing in cancer lately that oncologists are becoming more dependent on guidelines to help us, because keeping up with all of the data is getting to be difficult at times, okay? And I pulled the NCCN guidelines from 2020, and I went back and found a couple PDFs that I had saved from when I had done this before, just so I didn't have to keep pulling them up on the internet. In 2013, the NCCN guidelines were 138 pages, okay? In 2016, it was 168 pages, meaning we had about a 30-page improvement over 3 years. If you look at 2016 to now, we've had over 80 pages of addition to our guidelines. What does that mean? Well, we've almost doubled the amount of information over the past 7 years we understand about non-small cell lung cancer. And that's moving us toward, and you may have heard this, it's kind of a catchphrase, personalized medicine, right? Personalized cancer treatment, where we're looking at the individual, we're looking at their cancer, not so much as a lung cancer or even an adenocarcinoma, but as a EGFR positive lung cancer. We're continuing to get more granular with what we're understanding. And so I think, you know, when we look at this and we understand if we're doubling our information over, we'll say 8 years, because it's not quite a doubling over 7, that's amazing. And this has all happened because of research, right? This wasn't an accident. This is a concerted effort with our government and with our physicians and with our communities and with our patients and with the community itself to make an effort to do this. Because without patients agreeing to go on trial, we don't have the information. Without community support, we don't get the trial started. This requires an effort, and this effort has been universal, okay? And so, you know, I'm here presenting all this exciting information, not because I've done any of this specifically, but because there have been so many people adding to it, all right? This, once again, this is essentially a logarithmic curve. If we do 1 data point out there, 2 data points, and then 4, this is advances in lung cancer treatment. This is FDA approved medications. This isn't even compendium approval. This is just FDA approval. You'll notice we had chemo up until 2000, probably 2007, 2008, when we started to figure out we had targeted medications that worked. And then we saw a few more chemo, and then we've seen immunotherapy enter the market. We've seen 1 chemo drug enter the market and more molecular agents. And this is truly exciting to see this transition from this non-exact carpet bombing chemotherapy that we've had for decades to now moving to targeted therapies and things that are better for our patients, and not only better, more effective, but also less toxic, right? So this is exciting. And so we start off with surgery, okay? What's advanced in surgery? Our anatomy hasn't changed, but the tools that we have changed. So video-assisted thoracoscopy, or VATS, where they do a thoracotomy and a resection, typically of a lobe, was where there was advance. We now have, you know, surgeons, cardiothoracic surgeons doing robotic thoracic surgeries. And, you know, their technique, because they're working through smaller holes, it's faster recovery times, less pain, and in experienced hands, equivalent outcomes. And so this allows for kind of that next step for surgical interventions. Then we talked a little bit about adjuvant therapy, okay? And adjuvant therapy is a hard concept. So I'm gonna try to make sure that everybody kind of understands what adjuvant therapy is. So adjuvant therapy is a treatment that we give, and the treatment can be, medication, it could be radiation, it could be, some other intervention, but we do that after a curative intent procedure, whether that's surgery, whether that's radiation, to try to promote remission or increase the likelihood of remaining in remission, okay? Meaning have your cancer not come back, right? So what's remission? We can't find cancer anywhere. So many times after surgery, people are in remission. The problem is we understand there may be microscopic cancer floating around, which explains why even in stage 2 lung cancers, we have recurrence rates in the 30 to 40% range sometimes, okay? So what's a cure? That's an extended remission. And we don't anticipate the cancer coming back after X number of years. And that's different based on tumors. And we now understand that some cancers, even breast cancers, can pop up 28 years down the road. So we have to be careful when we use the word cure, but we also have to let people say, I finished that chapter, I'm moving on. So this table down below was a great kind of summary article that I found. And it looked at chemo, and chemo for anywhere between stage 1 and 3A disease. And you'll see, we had one or two trials that demonstrated more than a 5% benefit. But in general, some of those trials demonstrated no benefit. They weren't statistically significant. And so chemotherapy, while it was effective for adjuvant therapy, we've been waiting for something better. Well, June of this year, to our surprise, the Independent Data Monitoring Committee unblinded a trial looking at a drug called osimertinib. And that's a drug that targets an EGFR mutation. So about 15% of lung cancers, probably locally more like 8%, because it's typically seen in either distant or non-smokers, exhibit this EGFR. And they looked at patients after surgery, and they even allowed them to get chemotherapy. And then they randomized them, one group to get osimertinib, the other group not to get osimertinib. And what we have on that top line is the group that got osimertinib, and on the bottom line, the group that got chemo or something else but didn't get osimertinib, because we didn't have any evidence that this worked. In fact, previous trials with EGFR inhibitors have been a wash. They've been kind of negative. And we saw a significant difference in the two groups. In fact, an 83% reduction in their cancer growing or dying of their cancer during the time they were on this drug. And this data isn't mature yet, which is one of the things we're waiting on now. But they completed a total of 36 months. And at 36 months, they had almost a doubling of people that were alive and hadn't had their cancer come back. And we reduced the number, because osimertinib gets into the brain, reduce the number of intracranial metastasis as well at time of recurrence. We reduced that by over 70 to 80%. And it wasn't a large number, but it was a large percentage of patients, meaning, is this going to be the advent of what we consider advanced treatments for adjuvant therapy? So to prevent it from coming back? Yes, I think that a lot of people are adopting this. What about immunotherapies after surgery to improve outcomes? They're all recruiting, or they're in the process of completing, and we'll have that data upcoming. So I don't have any data right now. I thought this would be the data that we'd be able to show you if I had to guess, starting 3 to 4 years ago. It's taking longer to do this, okay? And that's probably a good sign, not a bad sign, okay? So not approved yet, but immunotherapy is exciting, all right? So we'll talk a little bit about immunotherapy in a second too. We'll go into that detail on systemic therapy. So the next part of this is radiation and chemotherapy. There haven't been big advances in chemotherapy and radiation together. That's similar to what we were doing, although radiation techniques have improved. And so I put two of the things I think are most important about radiation. Stereotactic radiosurgery, which is where we do multiple beams at higher doses, reduce damage to the normal tissue around the tumor, and deliver a high dose to the tumor itself. Now, I don't do this. This is what our radiation doctors do. But historically, you can see the different types of brain radiation there. We did whole brain historically. The whole brain gets beat up. It ages the brain maybe 10 years or so, and people don't remember as well. And, chemo brain is real, radiation brain is real, and this caused radiation brain, okay? Then we did something called more traditional now, where it's a little more focal. We may use, you can see probably 1 beam, 2 beams, 3 beams to kind of create a higher dose here, but leave parts of the brain untreated, okay? And now we move to stereotactic, which is even more exciting. Higher dose, there's a little bit of injury to normal tissue going through, but they're picking more angles of attack and reducing injury to the brain itself. And so we have better response rates and less toxicity. The other thing that we understand is intensity modulated radiation therapy, or IMRT. This is where they change the shape of the beam, and they also change the intensity of the radiation going in. And by doing that, they can spare normal and vital tissue in the area. So it reduces the toxicity to the surrounding tissue as well. And this is more important when we're doing radiation with chemotherapy because of the side effects of the chemotherapy as well. And so this is not necessarily new, but the machines are getting more and more advanced, and their ability to shape that beam is getting better and better. So the toxicity to radiation is dropping off as well because we're getting more exact, okay? I'm gonna finish off the last kind of curative intent discussion, open it up for questions, and then we'll move into systemic therapy, okay? When we look at radiation and chemotherapy together, there's been this gap of knowledge following that. And while we call it consolidative immunotherapy, this is really an adjuvant attempt to mop up microscopic disease that might be floating around. Durvalumab is a PD-L1 antibody designed to enhance the body's immune response and prevent cancer from being able to cloak itself and hide from our immune system. And the interesting thing is this demonstrated anywhere between a 10 to 13% benefit. And that benefit actually is kind of continuing to spread a little bit as we get further out. This was a year of therapy with the durvalumab, okay? And you can see that top curve and bottom curve. This isn't as big a gap as we saw with the molecular treatments, but understand this is overall survival now. So the top curve are people still alive. The bottom curve is people still alive from the base. And so you can see that even with the best therapies we have, there are still people dying. But the important thing is every time we can make a 10% or 13% improvement, that really translates to a large number of people with lung cancer being alive that might not have otherwise been alive, okay? So we move into systemic therapy, which is where all the excitement is today, and all the commercials, direct to consumer marketing for Opdivo and for Keytruda, for stage 4 lung cancer, right? So they talk about those things. This is where the excitement has been, because this has been our population that's been hardest hit and least likely to survive to that 5-year mark. And so when we start talking about cancer and metastatic disease and systemic therapy, I find it really hard sometimes when I'm trying to educate my patients about primary cancer versus secondary cancers. And I'm going to stop on this slide because there are going to be questions on this. I already know that, because this is where I get most of my questions in the office. A primary cancer is where the cancer starts. A secondary cancer is where the cancer lands afterwards. So if we had a lung cancer, and this is the example I have on there, if we have a lung cancer, there's a lung mass, and then we see something else in the liver or the bone, and then we go up and we biopsy the liver, and the liver says we have lung cancer in the liver. That's not liver cancer. That's lung cancer in the liver. We treat it as lung cancer. We don't treat it as liver cancer, okay? And so it's very important that when we're defining these, that we define the primary. The primaries may be becoming less important because we're now doing molecular testing, and regardless of where it starts, we know we may be able to use a certain treatment, okay? The best analogy I've come up with for this is if I travel to Texas, even though I'm somewhere else, I'm still myself, okay? Just like when lung cancer travels to liver, it's still itself, okay? And so it may change the way it behaves a little bit. So in Texas, I may choose to wear still me. All right, and it still responds to most of the same therapies, okay? And so since we kind of went into that systemic treatment discussion now, and we have this, which is sometimes a difficult concept, I'm gonna open it up again for some questions, kind of see if anybody has anything they have concerns about. Sorry, there it is, I got it pulled up. I'm searching the list, so I don't want to start calling on people out there. I'm just kidding. I won't do that.
We did have a question from Facebook, but it's not about this slide. So I don't know if you want to wait.
Well, yeah. Well, what's the question? Because I can scroll back through.
What studies are looking at cell-free DNA for lung cancer diagnosis?
Oh man, so there's tons. I'm gonna I have that slide coming up, so we'll talk about that because that's something that I'm super excited about. Okay, because tissue is sometimes limited, and because tissue is sometimes limited when we're doing these biopsies, because we're getting little needle biopsies, we don't always have enough to do the kind of testing we want to do on the tissue. So cell-free DNA, and more specifically, circulating tumor DNA, right? We want to pick up what the tumor's doing is fascinating, okay? And that kind of goes into this because our cells do get into the bloodstream. So when we think about systemic therapy, we kind of need something that goes everywhere, right? And so we have that spread. It can spread through lymph nodes, kind of the green little path here, or it can spread through the blood vessels, okay? And that's how it gets to the other organs, right? So when do we use systemic therapy? Typically for patients that aren't curative. We can't cure them. Now, what if they have one spot in the liver, one spot in the lung? We may try to cure them. That's called oligometastatic disease. But if they have several sites and we don't think we can cure it, that's when we talk about systemic therapy. The treatment at that point in time, instead of curative, we describe as palliative, meaning it's designed to help people feel better and live longer, okay? But not necessarily curative, okay? And so the advantages, it goes everywhere. The disadvantages, you have side effects wherever it may go. That's where chemotherapy was a problem, but where molecular treatments are a distinct advantage, okay? So we don't want to damage normal tissue. So this is getting into that circulating cell-free DNA, circulating tumor DNA, okay? And this is truly, when I think about where I finished off my training 11 years ago, if you had told me we would be able to pick up an EGFR mutation in the bloodstream in 10 years, I would have looked at you and said, we can't even identify that in the tissue today. There's no way we're going to be picking up in the bloodstream. But our techniques have gotten so sensitive, and I say ours, I can't take credit for any of it, but it's exciting to be part of it. Our techniques have gotten so sensitive that we're able to pick up and amplify some of those signals to the point that we're able to make clinical decisions based off of a blood test with that. So are there trials going on? Tons of trials going on. In fact, we have several trials going on here. There's a few ways you can use circulating tumor DNA. You can look for the molecular mutation that you want to treat. That's one way to use it. Another way to use circulating tumor DNA is if we do surgery and the circulating tumor DNA disappears, okay? And we monitor and we see that circulating tumor DNA start to rise, guess what? There was tumor we didn't find, okay? And then the last way to kind of think about it is if I start treatment on somebody and I see that circulating tumor DNA drifting down, guess what? We know we're having an impact on the cancer, okay? And that's actually been shown in different tumor types. Not all of that in lung yet. Some of that's been shown in colon cancers. One of that's pancreatic as well. There's some other things where we understand that's not completely vetted in lung yet, but those are some of the trials we're looking at right now. And we're actually looking at a kind of a pilot study even with one of those in stage 3 to monitor for recurrence with those stage 3 patients. When we saw that Pacific trial drift down a little bit, those people that are having recurrences or dying, if we could identify that earlier and switch them to something else instead of keeping the same thing going until it's big and we have less options. So yeah, so that's the exciting thing. And so, you know, we've talked about even doing circulating tumor DNA at the time of biopsy to get those answers. And you can see here, we talk about tissue, we talk about cytology, but we also talk about the liquid biopsies, which is based off of blood, okay? And I think in lung, blood is here and it's going to stay, okay? And in fact, it even enhances what we're able to get from tissue. So exciting stuff. And this is where, you know, it's exciting to find this, but it's even more exciting to find a mutation with this and be able to treat it. And I've had several of those patients now where we couldn't identify it on tissue. So the next part is immune therapy. So I kind of open it up. Did that answer the question? If they're able to type back into Facebook? or is there additional information they wanted?
That's it for now. If
That's
they
it for now. Okay.
post, then
Just
I
let
will
me know
let you
if it
know.
pops. Yeah, just let me know if it pops back up. Okay. So the next part of this is what we call checkpoint inhibitors or immune therapies. And immunotherapy has revolutionized lung cancer because while molecular agents work for a period of time, but eventually the cancer figures out a way around it, when we get the immune system rolling, sometimes it keeps that cancer under control for extended periods of time, okay? We say there's a tail on the curve, meaning the death rate kind of stops, okay? We're not seeing more people dying. And there's and in lung cancer right now, that's been leveling off between 17 and 20%, maybe even over 30 now in some instances. We do that by interfering with the way the cancer tries to fool our immune system. And we have two groups of drugs that target one, CTLA4, okay? That's two drugs that do that. And we have 5-6 drugs now that interfere with the interaction of PD-L1 and PD-1. Some bind with the tumor part, PD-L1, some bind with the T cell, but they keep that T cell, which is part of our immune response, from being shut off by the cancer, okay? What's the problem with that? Well, we have normal tissue in our body that expresses PD-L1 too, like the thyroid gland and the intestines and the skin, and all organs have some. We can cause side effects in those organs from the immune therapy, and those side effects are a lot like what we see with autoimmune side effects. So if it affects the thyroid, it can act a lot like a Hashimoto's thyroiditis with inflammation, or it can even cause low thyroid levels. So very, very, we're messing with immune stuff, which we didn't even think about 10 years ago. So what do we do with systemic therapy? Kind of what way do we progress? If there's a molecular mutation, we try to use that because that has the best response up front. It leads to the best outcomes typically as far as how people feel. If there's no mutation, then we look at PD-L1 expression. And there's several ways to test it, and we can argue about those afterwards from an academic standpoint. But in general, if it's more than 1% expression, you can use immunotherapy by itself or combination chemotherapy with immunotherapy. And if PD-L1 expression is less than 1%, you typically start with chemotherapy, but we can use chemotherapy with or without immunotherapy there. And then obviously we're always thinking about trials because we think the trials really are still where we need to be going because this is where the benefit's been seen for all these patients. These are the molecular targets that we understand. This was I should have pulled one up from 2013. There were like 5, okay? And now we're seeing this massive expansion. The cool thing is this was published in 2019, okay? So this was a year ago. We have 2 new mutations I put up in the right corner, an NTRK mutation as well as KRAS mutation, not included on this one, that are now actionable targets. We're going to be able to go after those with specific exact therapy. And you can see not all of these have an actionable drug that treat them yet. But since we're identifying them, I can tell you they're looking at the receptor, they're looking at what molecule will fit into it, and they're testing drugs on this in multiple models now. Most of that now, 3D imaging based and all kinds of cool stuff there too. But these are going to translate to therapies available for our patients. Okay, so we're excited. So here's EGFR. Okay, epidermal growth factor receptor. This was the first one in lung cancer where we said, gosh, you know what? People that we gave this to did really well. They didn't know why. So this article looks at gefitinib, which was one of the first generation, versus chemotherapy. The group that had a mutation, so the box A, did much better with gefitinib than chemo. And so they said, gosh, this is awesome. But there were trials where we didn't know that that was important. And you can see if they don't have the mutation, people do much better with chemotherapy. Okay. And this was one of the first demonstrations where we were able to say, gosh, you know what? It actually does matter. This mutation allows us to treat people with more effective therapy because at the time, gefitinib and a drug called erlotinib had just kind of been approved in lung cancer. It worked in 15%, but we didn't know why. We now figured that out because we found EGFR mutations. And those are typically what we call an exon 19 or exon 21 L858R. This is now a later generation EGFR inhibitor called osimertinib. And we mentioned that one once before in the adjuvant trial. This looks at the median progression-free survival in folks with metastatic disease who got osimertinib over gefitinib or erlotinib. And so this benefit that you see on the bottom curve is stacked on top of the benefit over chemotherapy you see on this top curve, right? If you look at that, you know, this is revolutionized. You can see about half the people at 18 months are still alive and their cancer hasn't grown. And we see a group of patients that are really, I have 2 or 3 without any evidence of cancer right now who remain on EGFR therapy. Not all of them on osimertinib, actually a couple of them because I started them prior to osimertinib getting approved in the first line setting. So fascinating, right? So we move on to ALK. Crizotinib came out 6 years ago, 7 years ago, 2013, give or take. So it's 2014 published, so probably 2014, right? It showed a 50% reduction in death or progression in people that got the pill, right? So pill versus chemo. It looked great. What's the problem? Those true curves came back together at the end. They separated and then came back together. We don't want the curves to come back together. We want people to have long-term benefits from these. So what happened? A drug called alectinib came out. This is another one of those stack on top of. Crizotinib's on the bottom arm there. The red is crizotinib now. The blue is alectinib. Chemotherapy would be below the crizotinib arm, right? So if you look at that, the median progression-free survival, which is how long somebody's alive without cancer growing, was 11 months on crizotinib. That's about the same as it was here. If you look at that 50%, that was right at 9 to 10 months, give or take, okay? Look at what alectinib did. 34 months, a 3-fold increase in disease control and survival. Amazing differences, right? I mean, this is revolutionizing what we're doing, right? So this was published about a year ago, a little over a year ago. We knew the data. This is probably some of the extended data. We knew these curves were separating about a year and a half ago, probably before this was presented, okay? What else do we have? We have MET exon 14. This is what we call waterfall plot. If you're under the bar, it means you had a response to treatment. So in people that had second and third line treatments, only 4 people didn't respond. The rest of the patients had a reduction in the size of the tumor. Now, we use RECIST criteria, meaning we only said there was a response in everybody that's below the dotted line. But still, amazing responses in this group of patients. And when we moved to first line, there were no people that had progressive disease. None. Amazing, amazing data. We've never seen this in lung cancer prior to the last 5 years. We have BRAF, we have ROS1, we have NTRK, we have RET. All of these mutations I'm mentioning, I didn't put trials in because it's going to look like the same curve over and over again. All of them have benefit, which is exciting, okay? And then we get to immunotherapy. And we're seeing now tails on the curve with immunotherapy. And you give immunotherapy by itself. You can give dual immunotherapy. You can give immunotherapy and chemotherapy. And you can give immunotherapy and chemotherapy. And I want to point out a line right here where this levels off at almost 40% at almost 2 years. Unheard of numbers in survival. These curves are flattening out. And look at the chemo curve. Look how well the chemo curve is doing. You know why they're doing well? Immunotherapy. So immunotherapy has revolutionized what we're doing. So when we look at this, and try to finish up here, we have improvement in our ability to detect and intervene early. We've had C. Everett Koop, who told us to stop smoking. We have better biopsy techniques, better ability to look at things from a pathologic standpoint, better things to look at a molecular standpoint, a team approach to treating patients, and all of these new therapies that are available. So I'll kind of open it up. There's a couple reliable resources I like. The American Lung Association actually has great information on this, but also ASCO, the American Society of Clinical Oncology, has a patient-specific website called www.cancer.net, and it's all kinds of tumor types they have on there. But their lung cancer data, their lung cancer information walks you through the steps and kind of brings you up to speed with what we understand about lung cancer today. So I'll kind of open it up for questions or comments or thoughts.
Dr. Persing, this is Tui Fang.
Yes.
Thank you so much for a really informative talk. And I really appreciate you mentioning pathology and the role of pathologists in this whole process, you know, along with oncologists and surgeons and our nurses and everybody else. So I'm the molecular pathologist at University of South Alabama, USA Health. And I'm just wanted to kind of share with you that the important biomarkers and genes that you have just shared with our audience. I'm really hoping and soon that we can actually do some of these molecular assays in-house with the benefit of turnaround time being much shorter, cost efficient, and as the molecular pathologist in-house, I will be on the phone available to answer any of your questions about our assay.
Yeah. And I think that's one of the most important things when we're talking about that team approach, because as you know, in lung, we don't always have a lot of tissue, and you may be having to call to say, hey, I need more clinical history so I can decide what's going to be the most important test for me to run, because if I don't have enough tissue, I want to make sure we have the highest yield with what I'm running these on. And so the successful programs that have been able to do this do exactly what you're describing, and that's making sure that everybody's on board. Oh, come on. I saw Dr. Al-Malouf out there. I know he wants to say something. There he is.
Yeah. Hello.
Hey.
Thank you so much for a great talk. Really appreciate you joining us in this community. Coming from Mississippi, we're very fortunate to have an outstanding clinician and leader with USA Health now at Mitchell Cancer Center. I just want to highlight one thing that you mentioned, and I appreciate it so much. The team approach between the pulmonologist, the oncologist, the pathologist, the radiologist, and the radiation oncologist, and how we all work together as a team to make sure our patients receiving world-class care.
Right.
So, I really very much appreciate that. We at USA have extensive collaboration among our specialists. We meet weekly, like we met this morning. Right. For tumor board and discuss the radiology, the diagnostic approach, the therapeutic options, and get input from everyone, from all expertise, so we can make sure we provide our very best care for all our patients. Right. So this is terrific. Thank you so much.
Yeah. Well, thank you for coming. I mean, I will tell you the EBUS and the ability to do navigational bronchoscopy. I mean, exciting things, because our patients are more likely to get an answer and more likely to not have negative biopsies. So it's exciting. So I know that we're going to keep working to make sure that that's more available.
As you highlighted, it's that pathology diagnosis and going for molecular studies going to be very important to subclassify the cancer so we can provide proper therapy based on evidence-based approach. When we do our bronchoscopy and obtain our biopsies, I have a pathologist right next to me. They review the studies on site, and they'll tell me, yes, you're in the right place. I see adequate material, or not so much, get more tissue, right? Yeah. So having that feedback directly from the pathologist at the bedside in the endoscopy suite, when we do our biopsy with radiology, I think it's crucial to, hit the lesion, right? And have adequate samples so the patient will not have to go through another procedure. And I think this is unique for our university.
Yeah. And it's growing. And I think that this is one of those things that's most exciting, is you have to have the pieces there to be able to do it. And the exciting thing is we have the pieces here. So I see not only all of these things that we have available, but all of the personnel that we already have in place to really be able to do exactly what we've talked about here today.
We're so fortunate to have you with us, and I am so looking forward to coordinating care with you for our oncology patients.
Me too.
From the molecular pathology side, I'm looking forward to working and seeing you in person someday. Day.
That's right. That's right. We're mostly Zooming. Yes. All right. Any other, oh, I got a chat up here. Hold on 2 seconds. We got, oh yeah. My pleasure. This is exciting. Lung cancer was at the bottom of the barrel 11 years ago because we really didn't have anything, and now it's the exciting one. And it's great to be able to offer patients better care than we've ever done. So I'm excited to be here as well. So thank you all for the welcome.
Dr. Persing, this is Rachel Finsky, and I'm a librarian at the Biomedical Library. And this talk is extremely timely. My father-in-law, who was 95 and a half, just died a week ago of lung cancer and was diagnosed on October 16th. My question, I'm fascinated by the treatments and everything. My question is, he had a sister who died when she was 20 of lung cancer, and this was way back in the 40s. Mm-hmm. Since he was diagnosed at such a late date, what is the percentage of individuals who could get lung cancer through genetics? Is that, a small percentage, or is,
The truth is we don't know, because we've always just blamed smoking. And so there is a genetic predisposition, and there's a few things, and we have, I didn't put on here, and I should have, I tried to make sure I was inclusive, but we have Cassie over here. She's one of our, she's our genetic counselor, and there are a few familial, genetic changes that do increase the risk for lung cancer. And I'd have to go look those up because they haven't been vetted well at this time. We understand BRCA in lung cancer, or BRCA in breast cancer, and pancreatic cancer and ovarian cancer. We understand Li-Fraumeni. We understand there's a lot of other, kind of familial associated cancer syndromes. The one thing that we've run into in lung is we've had trouble pulling that out. The interesting thing when we talk about like EGFR lung cancers, if you look at, especially kind of Eastern Asian populations, there's a high incidence of EGFR related lung cancers. And that may be genetic. We've just never been able to pull some of that out. And, I'd actually kind of throw it out to the molecular pathologist here today too, because there are some right now, based on the NCCN guidelines, there aren't standard recommendations for genetic testing in that population. But if we talk about a 20-year-old with lung cancer, we would be sending them for testing of some sort.
Yeah, and that was way back in the 40s. And my father-in-law did smoke, but that was 60 years ago. So, I mean, he was 90, almost 96.
Yeah.
So, but this talk was very, very fascinating, extremely fascinating.
Good. I was going to see, I didn't check my chat. Let me check my chat again. Too busy talking. Okay, good. Good check. Anything Facebook wise?
No, nothing else on there.
Okay. All right. Well, you can always get in touch with us. I'm our team communicates frequently. If you ever have questions or something comes up, we're available, and you can just give Mitchell Cancer Institute a call, and we'll be happy. Oh, I got a chat thing. Hold on a second here. No, just a thanks. All right. So just, if there's something that comes up, we're always happy to visit or talk through things or help like Dr. Amaluf said this morning, we had our tumor board, and I was asking everybody how best to get to probably a little area in the front part of the chest today. And so it's kind of one of those things, when we work as a team, we come up with a better plan than we do by ourselves. So I'd encourage anybody who has questions or would like additional information, just let us know. Ooh, I went too far. Sorry, guys. I was just trying to pull that last one up. Very good.
All right. Thank you, Dr. Persing.
Thank y'all.